Okay, I'm going to convene us. If I'll ask everybody to grab a seat. It's terrific to see everybody here. So good afternoon, everybody. Welcome. It's great to have you all here. My name is Sandro Galea, and I have the privilege of serving as Dean of the Boston University School of Public Health. And I'm here today to welcome you to this symposium on behalf of the School of Public Health, the School of Social Work, and the Center for Innovation in Social Work and Health. Welcome, and thank you for joining us. I want to start going back to 1926. At that time, New York Tuberculosis Society Director Harry Hopkins wrote, "The fields of social work and public health are inseparable, and no artificial boundaries can separate them. Social work is interwoven in the whole fabric of the public health movement and has directly influenced it at every point." I think history bears that out. Modern public health and modern social work both emerged in response to conditions created by industrialization. During the progressive era, they addressed the health effects of urbanization. Their collaboration areas have included, among others, maternal and child health, responding to epidemics. Today, social work and public health continue to care for populations by engaging with the broad range of social and economic forces that shape the health of populations. This afternoon, we are going to explore how social work and public health can keep working together to advance their shared mission. Before we begin, I would like to thank the School of Social Work Center for Innovation in Social Work and Health for its partnership with the school in making today happen. I would like to thank all our speakers. Thanks also due to the many staff at School of Social Work and School of Public Health who made this event happen. In particular, thanks to Maddie Wackman and Meredith Brown who made this happen. Thank you. And finally, thank you to everybody for joining us this afternoon for what I think promises to be a really interesting discussion. And now I'm going to turn the stage over to Jorge Delva, Dean of the Boston University School of Social Work, Director and Paul Farmer Professor at the Center for Innovation in Social Work and Health. Jorge is a friend from whom I've learned much, and I look forward to doing so again this afternoon. Jorge.
Good afternoon. It's a pleasure to welcome you. Thank you, Sandro, for those remarks. We are thrilled with our partnership with the School of Public Health. We at the Center for Innovation, Social Work, and Health are working closely in interacting with the School of Public Health, developing projects, educating our students, and leading these educational activities. So the Center for Innovation, Social Work is a center within the School of Social Work. We're focused on conducting research, practice, policy, and education to expand the impact of social work practice on health, to advance health equity and social justice, and improve the health of populations. Today, we're looking forward to an afternoon of presentations and discussions on the intersection of public health and social work, with a focus on health equity and population health. Today's challenges related to immigration, health reform, climate change, racism, growing economic inequality, and other forms of health injustice provide new opportunities for social work to embrace, redefine, and strengthen its role in health. Social workers have front row seats to the changing social, environmental, and economic determinants of health. We witness, along with our colleagues in public health, on a daily basis, the effects of a fragmented health systems on the most vulnerable sectors of society. Collaborations between public health and social work have expanded in diverse arenas, just as my colleague mentioned, from HIV/AIDS and the opiate epidemic to food and housing insecurity. As evidence mounts on the need to focus on the societal determinants of health, prevention, and other upstream interventions, the urgency to accelerate training of the social work workforce in public health is more apparent than ever. Today, we're grateful to have a group of incredible speakers representing several important areas in public health and social work. It's now my pleasure to introduce our keynote speaker, Dr. Charles Lewis, Jr. Someone I've known for quite a while now. Dr. Lewis is a leading advocate and educator who has elevated the voice of social workers on Capitol Hill and other hills around the country. In fact, Dr. Lewis himself began his career on Capitol Hill as the Deputy Chief of Staff and Communications Director for Congressman Ed Towns, a social worker who represented congressional districts in Brooklyn for 30 years. Dr. Lewis assisted Congressman Towns in establishing the first ever Congressional Social Work Caucus, serving as its first staff coordinator. The caucus provides a platform on Capitol Hill to represent the interests of the over 600,000 social workers in the United States and to advocate for their involvement in finding policy solutions to our nation's social problems. To support the activities of this congressional membership organization, Dr. Lewis founded the Congressional Research Institute for Social Work and Policy, As CRISP's current president, he leads the institute in informational forums and other events for social workers to interact with Congress. It also supports field placements for social work students in congressional offices. And under his leadership, CRISP organizes an annual Social Work Day on the Hill event in March during Social Work Months that brings together social workers from all walks of life to celebrate the accomplishments of social workers in Congress. And they do a lot more, but I'll stop here because we really want to hear our speaker. So Dr. Lewis is indeed a leading advocate and educator. Please join me in welcoming Dr. Lewis.
Thank you, Dean Delva, and thank you, Dean Galea, for inviting me here to speak to you this afternoon. I've been excited about this for a while, and I'm glad that the time has come. So I want to begin just by saying that I am a political social worker. Okay, now that may be a strange term to some people because we don't always hear it, but I am one of a small but growing group of social workers who feel that we need to operate in that political arena, in that space. And now we even have a textbook that was written by Dr. Suzanne Prisker and Shannon Lane. So that kind of makes us official. So what I'm going to have to say this afternoon is going to center around the need for social workers and public health professionals to be actively engaged in the political space. And that space is not just political offices, but also think tanks, institutes, advocacy organizations, those who influence the legislation and laws in those settings. All social workers, macro and micro, should be aware of and involved, when necessary, in local, state, and federal political activities. These are the arenas where resources will be allocated, guidelines will be set on how services may be delivered, and all of this is meeting the needs of the populations that we serve. So we must keep a vigilant eye on those discussions. And we need to be at the table when those policies are being decided. You know what they say? If you're not at the table, you just might be on the menu. I did not start as a political social worker. Like many of you, I joined the profession because I wanted to help people. For me, it was African American males in a church back in Brooklyn who I was working with. I got there in my late 30s after drifting through life without much of a plan. I had worked for newspapers for a while. I took a communications job at the Brooklyn Borough President's office where I first met former Congressman Ed Towns, but I really didn't have a plan for my life. I had dropped out of City College back in the turbulent 60s. Some of you may remember those, Dr. Bailey, when students were taking over administration buildings and shutting down campuses. I was studying mechanical engineering because one of my teachers at Brooklyn Technical High School, not because I wanted to be a mechanical engineer, told me that I'd be good at it. Had my father lived, my father died when I was in my junior year. Had he lived, I probably would have gone into politics at an early age. He was a pastor in Brooklyn and very active politically, a note of trivia, he ran for the state assembly against Shirley Chisholm. Obviously, he didn't win. But I was smart enough to keep a job. So my life, but ultimately, not having a direction, my life began to crash around me. Too much wine, women, and song. But then I found my way back to the church. I found my way back to the church, and there I went through I went into therapy for 3 years with an MSW, and it turned my life around. I became a minister, and I began telling the men and boys who were coming to the church that to turn their lives around, they needed to go back to school and finish their education. So after a few years, I realized it was time to follow my own advice. So at the age of 42, I went back to school to complete my BA. My first plan was to finish my undergraduate degree and go to seminary, because I was working in the church, and I was going to study pastoral counseling, because that was the closest I could find to therapy. I took classes at the College of New Rochelle, which was housed in the New York Theological Seminary, and I got my first taste of seminary, and then I decided I did not want to spend time arguing about what God was thinking. I wanted to get knowledge and skills I could use to help the men and boys at the church. I thought about pursuing a doctorate in psychology when the dean, whose wife was a social worker, suggested I consider social work. Social work? Who wants to be a social worker? That's what my first thing. You know, looking back, although I had been in therapy with an MSW, I guess I didn't see him as a social worker. My idea of a social worker was a caseworker. And then it was colored by the movie Claudine. Some of you may have seen this movie with Diane Carroll and James Earl Jones, where the social worker comes into Claudine's apartment and starts looking into closets and under the beds to see if there are anything of value or the presence of a man. So that was my idea of it. I had a very negative impression of social workers. But after meeting social workers in the church and discovering some of the amazing things they were doing with the homeless and addicted people, I began to see things differently. And then I had a fortuitous meeting with the late Morris F.X. Jeff. And not only did he convince me to go into social work, he convinced me to go to Clark Atlanta University, his alma mater. So it was there that I completed my MSW in clinical counseling. And I was hired after graduation by Families First, where I did my practicum. So I was pretty good at it. But along the way, I had been bitten by the policy bug in one of my classes. And I decided that I could have a greater impact on the lives of the brothers back in Brooklyn if I worked in the policy arena. While at Clark, I went to the Million Man March. Okay, it was important for me to go. And not only that, I went back to Brooklyn so I could go with the brothers that I had been working with. And it was a terrible ordeal. And when I returned, months later, I went to the library because I wanted to see what policies had come out of the Million Man March. I had a pocket full of quarters for the Xerox machines. You remember those days? And I was looking for articles. I searched for articles on policy that resulted from the Million Man March, and I found one. And the article said, there were no policies that resulted from the Million Man March. That's when I decided I would train myself to be a policy professional. And I applied to Columbia University. They accepted me. I had a wonderful experience, worked with some brilliant people, and then headed to Washington because I knew that was the policy capital of the world. I took a job with a consulting firm and working on a substance abuse grant, and it was okay, but it was just about money. You know, we were making money. If we helped some people along the way, fine. But this was a cash operation. And so I applied for an open job at Howard University. And again, when you go into academia, you need a plan. And I didn't have a plan. So at 52 years old, when I received my PhD, neither did I have a desire to write countless articles that no one would ever read. So academia did not work out for me, and Congressman Towns offered me a job on the Hill. And I decided I would leave social work and go into politics. That was my thinking at that time. And then I discovered, I could be a social worker and still work in politics. There were several social workers on the Hill. When I arrived, there was 2 in the Senate and about 8 in the House of Representatives. There are now 6 social workers in Congress. So I asked Mr. Towns about creating this Congressional Social Work Caucus. Because everybody, there was so many caucuses, Spotted Owl, and, So I said, social workers need a caucus. How many of you know that there's a Congressional Social Work Caucus? No, we got to do a better job marketing that. Well, the current chair is Congresswoman Barbara Lee, who represents California. And she was the chief of staff for Congressman Ron Dellums and succeeded him when he retired. And she was a psychiatric social worker when, applying a trade. So, micro-social workers can operate in that space as well. And then when I was preparing for my talk here, I discovered there's a Congressional Public Health Caucus. How many of you know there's a Congressional Public Health Caucus? All right. It was formed, the Social Work Caucus was formed in 2010. This caucus was formed in 2015. And so when I get back to Washington, I'm going to look up the Congressional Public Health Caucus, since we have this synergy thing going on between social work and public health. So I know a little bit about public health because, as a social worker, we do learn about public health, but I'm far from an expert. So I reached out to a couple of colleagues in my preparation, so I would at least look like I know something. So I reached out to Dr. Mary McKay. Some of you may know her. She's the dean at the Brown School at Washington University in St. Louis. And I wanted to talk to her because they have a school where social work and public health are co-located. So they share the same school, different disciplines, but they say one school, one faculty. So for her, ideally, faculty teaches across the 2 programs, and they have been able to bring their unique perspectives together. Social work tends to be more relational. We deal with individuals, families, and public health focuses on populations. But and then I got an opportunity to meet the new dean at Columbia University last week. Dr. Melissa Begg, who's taking over the program that I came from and Heidi came from, and she's a public health professional, so that's going to be interesting to see where she's going to lead the school. An important accomplishment of the partnership between social work and public health is that policymakers now have embraced the importance of the social determinants of health. So that a report which was released last month by the National Academies of Sciences, Engineering, and Medicine that outlines the need for further integration of social care into the delivery of health services. So as a political social worker and someone who works to bring social work research into the deliberations on the Hill, we often hold briefings and other events to bring social workers to the Hill to talk about the issues from our perspective. It's important that we be at the table to ensure that social determinants of health are included in these discussions. I saw on your website that Dr. Yusuk Ha has been awarded a $1.6 million grant to examine the relationship between the quality of subsidized health care and children's early outcomes. And I said, what a great opportunity to inform policymakers. And I'm sure as she proceeds, she's going to draw on previous research, but I hope she also look at legislation that has been introduced, maybe not even passed, but the ideas that legislators are putting forth on both sides of the aisle that may stimulate some different research questions. Too often, our research is disconnected from discussions on the Hill because there hasn't been a deliberate attempt to use research to inform specific policy deliberations. And that's not to say to do research to promote a specific issue or outcome, but that we ask questions so that our findings are germane to those discussions. So I'm currently working with Dr. Sherrod at the Brown School on child development accounts. And for those who may not know, these are savings accounts that are open for every child at birth. So every child will get a savings account of $500. And depending on your socioeconomic status, you can build on those accounts through tax deductible credits and other means. So when we began looking at, when we began proposing a bill on the Hill, because Dr. Sherrod has done this for Singapore and Israel and several states, but we wanted to propose a federal bill. We looked at bills that had been introduced previously, and turns out that even there was a bill that was introduced back in 2006 by Rick Santorum, promoting these child development accounts. And so we looked at the bills and tried to shape a bill that may get bipartisan support. So when Mr. Towns retired in 2013, I created the Congressional Research Institute for Social Work and Policy to work with the Social Work Caucus and to encourage more social workers to be active in the political arena. And then I met Dr. Nancy Humphreys, who guided me into this realm that I now identify as political social work. Being engaged in the political arena doesn't mean you should run for office, but there are many reasons why some of you may want to consider running for office or working in legislative settings. I spent 4 years working in Congress, and I know that the knowledge and skills and values that we bring into the arena are sorely needed. Today, we are not only concerned about the health of people in populations, some of us are very concerned about the health of our nation. Confrontational politics have gotten out of hand, and Congress has pretty much come to a standstill. The House of Representatives have passed a number of bills for DACA, the Dreamers, for the rights of LGBT people, populations, global warming, and all these bills are collecting dust in the Senate because they refuse to work together. There was a time when those two chambers could come together and reach some sort of compromise, but that doesn't seem, that time has seemed to have passed. The President of the United States is facing possible impeachment. And there has been an assault on many of the institutions necessary for a healthy democracy, the media, the courts, and the House of Representatives. So what does that have to do with us here today? We also know that economic inequality is off the charts. But we're not doing anything about it. Today, 1% of the population owns 40% of the wealth in this country. The bottom 90% of the population owns 23% of the wealth. That doesn't seem like a workable plan. And obviously, we see constant signs that global warming is really threatening our planet. July was the hottest month on record for Boston. Did you know that? I know you felt it. And June June was the warmest month ever on the planet. So global warming is a problem. And they say there's a saying that if you're not part of the solution, you're part of the problem. So that's why I encourage schools of social work and schools of public health to actively engage congressional district offices. You should have a relationship with your congressperson. Do you know who your congressperson is? Okay, well, I did a little checking, and Joseph Kennedy and Ayanna Pressley represents part of both schools. And so I think those are people that you need to engage. I remember when I did a briefing for a school, and I said, you should invite your congressperson. We're doing a Hill briefing. Oh, she's a Republican. I said, so she's a congressperson. And she came, and then after the presentation, she said, wow, I didn't know you guys were doing all that. What else are you doing over there? So she shouldn't have to ask. You guys need to reach out to your congresspeople. So I am on a mission to get more social workers involved in that political space. We got some programs that we're going to be introducing, like a Congressional Fellows Program, where students can do their field placements in district offices around the country. And then we've got to do something to get young people to the polls. And I think young social workers have the skills and the training and the knowledge that they can be catalysts and try to move this forward. And they're doing some of that with our Voting is Social Work campaign. If you go to votingisocialwork.org, you can see some of the things that they're doing. There are so many things in this country that we can do better. We could do a better job of educating our children. And this is one thing that we have to ensure that all kids, regardless of their zip codes, because of property values, and the color of their skin, all kids should receive a quality education. If we're going to compete with China or whoever, we can't afford to let generations of children fail to reach their full potential. And we ought to start by paying teachers a decent salary. Amen. As social workers and public health professionals, our values transcend ideological differences. Okay? We all agree that all human beings deserve quality health care. And to be healthy, every person should have a decent place to live. Everyone should have healthy food to eat. And we all should have an environment with healthy air and clean water. Can we all agree on that? All right. So tomorrow I'm going to be meeting with the deans and directors of social work schools. And I'm going to be telling them that they need to be more active in this space. And because a couple of years ago, I raised the question, can social work help save democracy? Okay? If democracy is in peril, what are we going to do? Are we going to stand on the sidelines as history is being made, or are we going to find some way, some solutions to be helpful? I'd like to close with a quote by the late Congressman Elijah Cummings, who passed last weekend. He was a remarkable individual and a rare type of leader. He will be missed. He said earlier this year, when we're dancing with the angels, and I hope Elijah is dancing with the angels, the question will be asked in the year 2019, what did we do to make sure we kept our democracy intact? Did we stand on the sidelines and say nothing? Did we play games? Our shared values, social workers and public health professionals, will guide our work together in the political sphere. We alone may not be able to save the planet, but together we can make contributions that will help ensure we have a better world. Thank you.
Thank you, Dr. Lewis, for your inspiring words and the encouragement for all of us to be more politically involved. I think there's so much room to grow, both in social work and public health. So it is now my pleasure to introduce to you another social work pioneer working also in public health. Moderating today's event is Dean Harold Cox. Harold Cox is Associate Dean for Public Health Practice and Associate Professor of Community Health Sciences at Boston University School of Public Health. Trained as a social worker, he has extensive experience in direct services, administration, and advocacy in a variety of public health care settings. Dean Cox directs the Activist Lab at the BU School of Public Health, which engages the school and community in real-world advocacy to drive lasting improvements in the health of local, regional, and global communities. Prior to joining Boston University, he served for 10 years as Chief Public Health Officer for the city of Cambridge, Massachusetts, and was responsible for managing all aspects of the city's health department. Dean Cox has been a strong supporter and leader of the MSW MPH program for many years, where we are grateful for his partnership. I will now turn it over to Dean Cox to introduce the panelists. Thank you again for being here.
Good afternoon. So, public health and social work are cousins. And today I love my cousins. So I'm very glad to be here and very glad to have all of you here as well. In particular this afternoon, my job is to engage in a conversation about how social work and public health come together. There are about 700,000 social workers across the country, and at least about half of those individuals are working in the area of health in some way. However, we know that much of the work that many social workers are doing are pretty much downstream. They are doing important clinical work. But it's very important for social workers to also be working upstream as we think about the variety of different kinds of ways that we need to address the health of the population. One of our colleagues said, well, you know, social workers already do that kind of stuff anyway, and sometimes it feels like social workers are the stepchild at their own table. So today, we're going to have a conversation about that. In particular, we're going to be talking about what does social work bring to the discipline right now? What do we bring to the table? And what is it that we need to change? What do we need to improve on in order to be at that table as well? This afternoon, we have a panel of distinguished individuals who are going to help share some information about those two ideas of what do we bring to the table and what is it that we need to improve in order to be at the table. And I'd like to tell you who they are and what their affiliations are. And then what will happen is they're going to each come up and spend a few moments sharing with you their perspective. Then we're going to come up here and have a conversation among ourselves, and then we want to engage you in the conversation. And what I want you to think about is, what does social work contribute? And what does social work need to work on to improve in order to continue to be valuable members at that table? Our panelists this afternoon, in the order that they will come and present to us, are Betty Ruth, who is a clinical professor and also the director of the MSW MPH program here at the Boston University School of Public Health. Dr. Linda Sprague Martinez is the associate professor here at the Boston University School of Public Health. Jennifer Valenzuela is the Chief People and Equity Officer at Health Leads. Dr. Heidi Allen is an associate professor at Columbia University School of Public Health. Professor Fernando Ona is a clinical associate professor of public health and community medicine at Tufts University, and he's also a clinician at the Boston Center for Refugee Health and Human Rights at the Boston Medical Center. Now, what I can say about all of these individuals is that they have impressive careers, they have impressive resumes, they represent areas of social work both in clinical side, the macro side, community health sides of social work. They belong to all of the right organizations. They publish in the right journals. They are thought leaders in social work, and at least one of them, is a provocateur. I want to invite Betty Ruth to come up.
Hello, everyone, and thank you. And I want to acknowledge our deans, Galea and Jorge Delva, and thank you, Harold, for the introduction. And thank you, Dr. Lewis. It was really a pleasure to hear you speak. So I appreciate your words, and I want to support everyone in running for office, right? So I'm here to talk a little bit about education, and I have exactly 11 minutes to do that. So as you know, I have dedicated pretty much my entire life to public health social work education, so I'm going to really zip through this. I hope I'm working correctly with this instrument. Oh, cool. So it's always nice when the technology works. Health social work in the current environment, strategies for increasing social work health impact, social work in health impact model, and public health social work being two of the primary strategies that I want us to really be thinking about together. And then finally, how do we educate for public health social work practice? So here's our current health landscape. It's pretty much a maze. I'm sorry, I'm struggling with this a little bit. The delivery of health services occurs in a system that emphasizes disease treatment over prevention, uses a maze of bureaucratic structures that show no sign of slowing down to contain spiraling costs, and fails to meet the needs of a large portion of our population. We have a lot of challenges that are driving us to population health as social workers, and I'm not going to go through all of these. You are all pretty familiar with them. A lot of unmet social needs, inequalities, population changes, and of course what we think of as our major driver of change, or our super driver of change, the Affordable Care Act, which unleashed many new opportunities and initiatives which social workers are taking part in. So you'll notice I bolded out the part about prevention, public health, social work, and wide lens practices to improve population health, because that's really our focus here today, to think about how we have impact on the health of populations. I want to say a little bit about health social work, because I think sometimes these terms are really confusing for people, and I want to just make sure you understand what I'm talking about, and you can quibble with me if you want to later during the panel. But social work's one of the fastest growing professions in the US, and although this has been an argument, I don't think it would be an argument in this room, because I recognize a lot of you, and I know you know that we agree on this. Social work is a health profession. Roughly half of the nation's social workers work directly in health, and pretty much the other half work on the issues related to the social determinants of health, those things that we think of as outside the health arena, housing and military social work and criminal justice social work and child welfare. On any given day, I love this statistic. Approximately 1.6 million people are in some sort of helping relationship with a social worker. That's a lot of people hanging out with social workers. So concern over the adequacy of the social work workforce is a perennial consideration, and we want to be thinking about that as we encourage all of you to go into politics, because we also need you to stick around and do actual social work in our systems as well. So there are a lot of different kinds of health social work. Here's a couple terms, but some of you I started out in hospitals. You may remember when we called it hospital social work, and then it became medical social work, and then it became healthcare social work. Now we talk about social work in health settings. I know there are some health social workers here. Am I missing any term here that I should have actually included? Let me know. Disease-specific social work, site-specific social work. We've moved from talking about psychiatric social work to mental health social work to behavioral health social work, and finally, public health social work. Those people who work on public health issues in public health settings or use a set of public health approaches to do their work in the field. As Harold said, most of health social work occurs downstream. Despite our historic commitment to person in environment approaches, our predominant focus, probably 80 to 85% of all social work services, are what we would call clinical services, focused on diagnosis and counseling, treatment, crisis intervention, and all of the things that we think of in the big clinical toolkit. We know those are profoundly important to individual and family well-being, but they have limited impact in promoting health equity and improving population health outcomes on a wider scale. And so that's why we're here talking about population health and social work. So the question is, how do we increase our role in population health? And there's two key recognitions I want to make with you. Guess what? All social work is health social work now. There is no outside of this anymore. Social workers are either working directly in care or we're working on the ways that health is determined, okay? And second is that we have to widen the lens in education as well as in practice. And I realize it's difficult in both, and I would say also as well in research. It's hard in all of those arenas to widen the lens to include population health, public health, prevention approaches. But that's what we have to do if we want to have population health impact. So here's a couple strategies for thinking about that. I think of these as models. I'm sharing, remember I'm the educator here, I'm talking about the educational. One is to think about a social work health impact model. Many of you have seen Frieden's of the CDC health impact model that he created. With all due respect to him, Maddie Walkman and Jeff Wilkinson and a number of us have been involved in adapting that model so that it can be useful to us in social work. And then I want to talk a little bit about reclaiming, revitalizing, and elevating public health social work specifically. So here's a little bit about the health impact model. You can see that where we spend most of our time is the tip of the impact model. Up there is all that good stuff that I described to you that many of you are involved in terms of clinical practice. If you move down to the base of the impact model, however, this is where the conditions of people's lives occur. And this is where the hard work happens too. And this is where the population impact is to be cultivated and created. For us to have an integrative health model, it helps us, okay? This is actually a unifying framework for all of the work that we do in social work. This is not to say clinical bad, macro good, macro versus clinical, none of that business. This is an integrative model where all aspects of social work have something to contribute to population well-being, and then people begin to move multiple levels to, across multiple levels to do the work. So why do we need a guiding framework for revisioning social work? Primarily because we fight a lot among ourselves about what social work really makes change and who is engaged in change, but mostly because we really do need to link clinical and macro skills to public health approaches at this time, and the health impact model can help us realize our intended impact on population health. The second is that it gives us some ideas about how to improve our educational systems, and I want to talk a little bit about how do we create practitioner readiness for things like leadership in prevention, transdisciplinary collaboration, systems innovation, deliberate and intentional epidemiologically focused efforts on changing the social determinants of health. The second thing I want to talk about is reclaiming public health social work. For the half of the people who are here have heard me talk about this for the last 30 years. I apologize. So this is a subdiscipline, a framework, and a set of unifying approaches to help us address major health issues and promote health equity and mitigate health problems and increase our population health impact. It's not new, and Dr. Galea, Dean Galea already cribbed this quote, so I'm going to just show you the picture. Harry Hopkins was FDR's senior advisor and a social worker who helped to create the whole edifice of social welfare that we have. And he, before he became that, was a dedicated public health social worker. Very briefly, you've heard this already, public health social work became one of many types of social work, but our origins are in public health. And early public health social work is very similar to contemporary public health social worker. You can see social workers working in milk stations here. This is New York, but you can see some of the criteria. I think the most important things here are to really appreciate the degree to which social workers used early epidemiology to inform their approaches at the turn of the 20th century, and had an understanding even then that social determinants of health were what we were up against, and that there needed to be an explicit focus on social justice and macro change. Today, and I want to acknowledge my colleague Jeff for helping me put together this slide. Jeff Wilkinson and I have worked on this, really trying to create a slide that reflects a contemporary public health social work model. You'll see all the components here. We don't leave anything out. We're using public health, we're using social work, and it's dedicated to systems change, right? So why do we have to reconnect? Because we did get separated. Harry Hopkins was wrong. And good things happen when we come back together, because we are cousins. And so a century's worth of expertise on how to maximize clinical, intermediate, and population approaches to improve our health, to improve health in our society. So I'm going to move on and just talk in the last minute about how to educate. We have some issues as educators. We still continue to see health as a niche area of practice, and we mostly teach to the tip of that health impact pyramid, and our terminology is quite inconsistent. Our lack of agreement about what the skills are that we need to practice in health, and finally, we've got these great things for teaching about public health, social work, and population health, but they're expensive and they're proliferating, and very few of them actually teach public health social work. So I'm going to make a couple of recommendations. The first is that I would really like that our profession grasp that our success will be tied to our capacity to engage in population health going forward. And we need to broaden our conceptualization of health social work. Schools need to understand that we are not teaching about a niche area of practice, that basically we're educating health practitioners, that social work, social justice goals are unrealizable without public health, and finally, that all social work curricular domains need to be recalibrated to reflect that. Finally, and I know many of you here as practitioners, I want to really recognize that the workforce needs the cooperation and collaboration of professional organizations and schools and researchers to support innovation in training in the workforce. Acknowledging a couple of, nothing up here that I've said has been developed alone by me. I want to acknowledge Maddie Walkman and Jamie Wyatt Marshall and my working group, the Group for Public Health Social Work Initiatives, who have been working with me on this ongoing conversation for many years. And some of the slides were the result of the work that we did in the Advancing Leadership in Public Health Social Work grant. Thank you.
I get going, I just want to get a grip on the technology, of which I can find none. Betty, you move so fast. All right. Okay, so I'm Linda Sprague-Martinez, thanks, and I'm going to talk a little bit about social work and the health of communities from a macro social work perspective. I sit in the macro department at the School of Social Work, and I'm not, as folks are not always as familiar with macro social work, and so I'm going to talk a little bit about that as we go forward, and the role of macro in community health specifically. And so I'll talk a little bit about what is macro, why is it important in the context of health, particularly now as we are conceptualizing health, who are macro social workers and what tools do they bring to the table in working with public health practitioners and other health professionals, how do macro social workers partner to advance community health, and what are some of the opportunities and challenges that are out there. And so if I just show of hands, just so I know the audience, how many people have heard of macro social work before? Oh, this is great. I feel like I'm home. Okay, so wonderful. And it's called a lot of different things across schools. My colleague, Christina Brinkerhoff, did a project recently where we looked at the top schools of social work, and we looked at how many people use the term macro social work, and only 5 schools actually use that term. And so we said, wow, what terms do people use in that case? And so we saw all sorts of things, anything from policy practice to social management, but that was one thing social management, no. Social administration and management. It was one thing we saw, this inconsistency across schools. But in terms of macro social work, we're really thinking about change in larger social systems, whether that be within organizations and organizational change strategies. We're thinking about municipal government. We may be using tools such as zoning and code enforcement to create change, as well as regional change and state and county policy. And one of the key factors that drives our work in macro is that we recognize that systems aren't broken, right? A lot of times we talk about, well, the system's broken, we have all this inequity. No, it's not that systems are broken. They were only designed to work for a few of us, and not the rest of us. And so that's a key as we think about macro, is how can we work with systems to make sure that they serve all people and the most vulnerable. So with that, we have a lot in common with public health practitioners in terms of increasing reach. And within macro, we're also very concerned thinking about power and how power plays out and how do we ensure the equitable distribution of power. And so tools that we're using are around resident participation and engaged decision making. We're thinking about resource allocation and asset-based programs and policies, and how do we ensure that all people have opportunities. As I look at this story of change in terms of equity versus liberation, I think of this podium. This podium was not designed for me. I can barely see you all. So, in terms of thinking about implications for community health, well, I think Betty said this as well, is that, we're part of, all individuals are part of a larger system and part of broad systems that influence our health. When we work in partnership with communities and we talk to folks, they're not talking about disease-specific areas. They're not talking about, we need to focus on, in our community, diabetes, or we need to focus necessarily on cancer, but more so we're likely to hear communities talking about issues such as gentrification. We're hearing communities talk about issues of affordable housing, access to food, transportation systems. And so those are things as communities are conceptualizing health. So we need to be able to meet them where they're at. This is my favorite. I can never have a slide presentation without this model because it just helps me to think clearly, whereas some of you might look at this and say, really? That helps you think clearly? Gives you a sense of where I'm at. I first saw this image back in 2003 when I worked for the Office of Minority Health, and people always talked about, and I should say I started out as a clinician and not a social worker, but a clinical mental health provider. And when you're a clinical mental health provider, you don't necessarily learn about those larger systems in context. You don't learn about the ecological model. And so people were always speaking of this ecological model. And I had left clinical practice just knowing that it just didn't work because people kept coming in, and I said, well, I don't understand what the issue is with housing. And then as I went to housing with my clients, I left crying, and they were like, Linda, it's going to be okay. And so one of the reasons is people talked about the ecological model, and I tried to wrap my head around it. This article had come out when I was working with the Office of Minority Health, and it all suddenly made perfect sense to me, the upstream versus downstream. The circles didn't work as well for me, but as I began to see the connections between these broader macro political factors, social context, and the ways that it influenced individual health, I could easily see. And so I think that say all this just to illustrate in terms of our commonalities with our public health cousins is that we both work upstream and downstream, and as we think about intervention. So in terms of thinking about the fields of where we find macro social workers, in case you're interested in a partnership, is that we see macro social workers in healthcare organizations. We see them in urban planning, we see them in housing, education, social services, justice organizations, unions, and the like. And our key tools that we use as practitioners are really focused around social action, popular education, community development, program planning, strategic management, and assessment. Does that sound familiar for public health practitioners, right? A lot of overlap. One of the key differences that we use is really thinking about the role of self, because at the end of the day, we're social workers. And our key tool that we have is our own self and our relationships that we're able to develop in our approach to this work. So the work that we're doing is much more bottom up as we begin to program plan, and working from a recognition that our job in working with communities isn't so much as to educate communities, but to learn from communities on what their priorities are. And so that's a little bit in terms of thinking about a different approach. So I have this slide here that I thought I would illustrate a few public health social work partnerships to promote health. Are you all familiar with those two individuals at the end that are sitting in an area looking like on some construction? Who recognizes those folks, right? Who are they? Jack Geiger and John Hatch, right? The two founders of our community health center movement. And this is kind of when we first started focusing on the social determinants of health, and we started thinking about transportation as health, education as health, with the original community health centers back in the 60s. But who knew that John Hatch was a social worker, right? Behind the movement. A lot of times we forget that piece. Additional examples are local examples. Maybe folks have heard of the community assessment of freeway exposure in health, or the CAFE study. It's a large a study funded by NIEHS Kresge. Looks at near highway exposure in health, looks at the impact of ultrafine particulate matter on cardiovascular functioning. That study was actually triggered by the work of a social worker, a community organizer and activist named Ellen Reisner in Somerville, who together was organizing folks around the highway and said, we're really concerned about our air quality. Went to public health researchers and said, how can we partner around this issue? So other examples I have here from the Nuestro Futuro Saludable study, which was engaging young people in public health action around the social determinants of health, as well as Gentrification and Health Forum that was spawned by the Dominican Development Center, that brought together where social workers, macro social workers, and social work students partnered with the Dominican Development Center to bring together public health leaders and folks from across city government to begin to talk about gentrification as a public health issue, beyond just a housing and displacement issue. So there are a lot of different ways in which public health and social workers are coming together. And perhaps it's easier in practice than it is in the academy, because the boundaries are less, right? And so some of the challenges and opportunities, I think the biggest challenge is the invisibility, which was alluded to in some areas. And perhaps it's just marketing in terms of how we market social work or how we market macro social work. But also, I think the issue where Betty spoke to of education is critical, and how do we really work with social workers to focus on professional identity development. And a lot of times I'll talk to macro practitioners, and they don't always identify as a macro practitioner. But they'll talk about being an urban planner or a community development specialist or working in philanthropy. And then you begin to talk to them, well, how do you get to where you are? What's your training? Well, I have an MSW. Well, why don't you identify as a social worker? And so what is that we're doing that allows our professionals to go into fields and become invisible, or the social workerness of them be lost? And so that's something I think we can think about. The other issue I think that's important to recognize, particularly in social work and public health in the context of the academy, and around thinking about hierarchy and production mentality and how that divides us. By just being in separate schools and the difficulties of working across schools, and what the values are in terms of the expectations around grant making and teaching, and why it can be that one professional can't move across and teach in another school so easily. But the politic around that, I think, is something that we have to think about if we're really going to educate in an interdisciplinary way and be able to work together and learn together. There's also, I think, that in terms of opportunities, there are many more, but I ran out of space on the slide. In terms of a renewed focus on the social determinants of health, it's a prime time for public health practitioners and social workers to come together. I also think the interprofessional training is another exciting opportunity for public health, social work, and other health professionals to come together. We're working on a pilot right now with general internal medicine, doctors to train medical students and social workers together in a virtual environment around focusing on screening for the social determinants of health. And it was ironic in the beginning when we started because they were doing all this work around social determinants, and they were like, oh, maybe we should have social work there. And I thought, why are you thinking of this now? Why weren't we thinking of this in the beginning? But we'll be there because we always show up. I think that's the one nice thing about social work. So that's it.
Great. Hi, thank you. Thank you, Deans, Galea, and Delva, for the invitation for today. I'm looking forward to this afternoon. So I'm Jennifer Valenzuela. I'm a public health clinical social worker, is how I usually identify myself. And my history is I actually worked for over a decade at Children's Hospital and then moved over to what's more considered the macro administrative side of social work, but feel like every day I really bring the two together. And feel like my whole career I've been able to bring those two together really well, and I'm really appreciative of that. So I was asked today to talk about the social determinants of health and also an example of the organization where I come from, which is called Health Leads. It's a national nonprofit, and use that as an example of the public health social work coming together. The organization, just so you have a little bit of an idea, it is a nonprofit. It is what's called a social entrepreneur organization, which is a little bit different than your typical nonprofit, which maybe has been around for decades. This is kind of the startup version of nonprofits, and so there's a whole lot of change that happens within this type of organization. A lot of different faces that are coming in and out. And then also the real focus is about making a change in the sector. So you'll see these types of organizations in the educational system, in the social justice system, in the criminal justice system, and in the health system and in others. Maybe they'll come up. Okay. So we've been talking about the social determinants for quite a while, and just so that we make sure, the definition that I am working off of is the World Health Organization's definition, which is the conditions in which people are born, grow, live, work, and age, and the drivers of these conditions. And so the graph on the right, most of you have probably already seen this, but really what that's showing is if you're looking at health, about 80% of your health is actually determined based off of your social determinants, and really only the clinical care piece, so getting to that doctor, getting your medicine, having an appointment, is only about 20% of health for yourself. And so usually, there's another slide that I didn't add to this time, but about 80% of our dollars in the healthcare field are being used on those 20%, that top 20%. And so we're really out of balance in how we're using our dollars today, and I'm hoping that that's really going to start changing. So I also wanted to make sure that we had some differentiation between health-related social needs and social determinants of health. What we've definitely seen happen over the last few years is social determinants of health has become the buzzword, right? Everybody says it. Most of us now know what that means. When I went to Health Leads about 8 years ago, and I think that was a term then, yes. I would say that, and people would say, huh? And now that's not a question. People aren't wondering what that is. You really, unless if you're outside of the health field. But really, if you're within the health field, people understand it. And so what we've seen, though, is as the clinical systems have started incorporating the screening around food and housing and transportation, they're calling that the work of social determinants of health. But really, if you get a little bit more specific about this, you're really working on the individual health-related needs of that person. And so the social determinants is really about the population health piece of that. It's really making the change in the system so that our food insecurity as a population is not happening anymore, or the housing insecurity is no longer a piece. And so I just want to make sure, like, as we're talking about that, I've been getting educated around this, and just want to make sure we're all thinking about that. And was a great article that our local John Auerbach wrote in Health Affairs earlier this year, and talked about this really well. And this was also another graphic that they had in that article, and really starts to talk about the social determinants and how do you start moving upstream? How do you really start thinking about, if we want to talk about the health equity pieces of this, if we really want to change our systems and not be doing the same things that we're doing today, 20 years from now, and still having the same issues with our families, or trying to get through the same barriers, that we've got to go further upstream. We have to start thinking about the policies. We have to start thinking about where the funding is going around these things, and we have to make just more broad systems change. And I think, Linda, how you said it right, the systems were built for just a small few, and really the eyes are starting to open up around how do we dismantle those systems and really rebuild and think about that differently. And so the journey for Health Leads has been quite long, and as I was working on this, I realized we started going upstream over the years. And so I just want to share a little bit about that journey of an organization that really went from direct services, but I think we never really embraced that very much. We were a change agent, and so as a social entrepreneurial organization, we weren't trying to be a direct services organization, but hindsight, we were. So these are our 4 different strategies that we've been a part of, and so I'm going to just break down each one quickly. So the organization Health Leads started actually is called Project Health back in 1996. It was co-founded by a college student who was going to school here at Harvard, Rebecca Oni, and this was pre-HIPAA days, and so she went to Boston Medical Center Pediatrics Clinic and had just read a Globe article about, her dad gave her an article from the Globe about something about food insecurity with patients. And so she went to Boston Medical Center and met with the head of the clinic at that time and said, what's the biggest problem that you face for your families? Like, what are you grappling with? And he said, we really have like a don't ask, don't tell. And we don't ask about food. I know transportation is a problem. I know housing, when they're leaving here, their housing conditions are not great. But we just don't ask about it because we don't know what to do around that. And at that time, I think they had just a couple of social workers for 10,000 families, 10,000 patients. And that's kind of the norm that we see still today. And so Project Health back then was really this undefined direct service and youth development program. So it really was a group of college students that were volunteering together and doing lots of different types of programs. They were doing advocacy, they were doing sickle cell programming, they were doing a swimming program, they were doing a needle exchange program in Baltimore at one point. It was kind of all over the place. I actually think we were in an education program at Children's Hospital here in Boston before I moved to Health Leads from Children's. They had just left Children's and doing that advocacy work. And so during that period, the co-founder, Rebecca, then realized, okay, if we actually want to make a difference in this sector, if we actually want to make a change, we need to focus. We need to make hard decisions, and we actually need to think about, like, where are we best? And so at that time, the vision that what we stated was that we were looking for a healthcare system that addressed all patients' basic resource needs as a standard part of quality care. So we really were focusing on the healthcare system. We wanted to make sure that all of our health systems were really thinking about food, housing, insurance, heat, transportation. Domestic violence sometimes went in there. We didn't talk about that a ton because I felt really strongly that we weren't clinical social workers. They were college students, and so that needed to be in partnership with the social workers at the clinics. And then our mission at that time was twofold. It was about our patients, and then it also was about a leadership development program. We were really thinking about building a pipeline of leaders with our college students. And so that was where we were focusing. And I share this because our mission really changed as we went further upstream. So we made these tough decisions, and we moved into our first major strategy, which we called our proof plan. And that was when we needed to figure out, like, what was our model? What was our program model that we wanted to make sure we could grow and that we could replicate over and over across the country? Back in 2009, when they were building this out, some of these nonprofit types, you try to grow really big. And so the bigger you are and the more locations that you have of that, then maybe the sector kind of grabs on, and then more people will do it like how you do it, and then it changes the whole health system. That's what we thought would happen. And so we decided that primary care was really where we were best in practice, and working in partnership with the health systems around integrating a screening program, figuring out how do you ask your patients if you have food, how do you get your systems together so that you have your databases and your staff actually know what their bounds of work are and their scope of services. And so we had about 1,000 students a year, and that's about when I came in, and our staffing system at that point, who was working in all of the clinics, were our recent grads. They were they were some of the brightest of the graduates who had finished being a volunteer, and then we would hire them on as our program managers. And so when I came in, I changed that, and they became social workers or public health clinicians when they came in, because it was quite evident to me that we were working with families that were really needing support around things, and the students were hearing stories that they needed more training around and support around. And I do believe the college students are another way to think about a workforce, that it doesn't just have to be social workers, and they also needed to have the supervision around them to help them work through this. So then, through that time, we dropped our mission, which talked about students, and we just kept our vision. So we really stayed focused on the health system, and the leadership pipeline became more of in the rearview mirror for us. And so we stayed with our students, we had our students, but that wasn't so much of our focus anymore. We really felt like we needed to focus on the health systems. And we were seeing more and more health systems starting to adopt this or be friendly to the idea of thinking that food or discharging a homeless patient actually might impact your return rates of your patients coming back and re-hospitalized. Okay, so then we moved into our next strategy, what we called our Grow and Catalyze plan. And this is when we went from doing the direct services, having our desk model, and where we thought health systems would actually want to take on that model and replicate it themselves, we quickly learned where they were like, we actually don't want your model. We want the tenets of what you learned from doing this and bring that to us, and we want to do it with our own workforce. We want to do it with our community health workers. We want to do it with our social workers, our nurses, our doctors, and just tell us some of those pieces. So we really shifted from 2014 to 18 to more of a consulting model and an enabling model, where we said we can go further faster. This health system can go further faster if we enable others and give them the information they need and integrate it within their own systems. And so as we were working on this, we were going further and further upstream. And so really where we started was the far right, which is the downstream effects. This really, it's the same as the upstream, downstream, but it just shows you how it looks a little bit different the further you go upstream, that you're getting more to the really the inequities in the systems that need to be changed. And so Health Leads in those first years was further on the right. And as we're moving along, we're moving further upstream. So let me actually go back real quick. So we changed our vision, we changed our mission, we changed our branding, we changed everything. But really, just about a year and a half ago, we changed all of this because we felt like to really show that we were moving further upstream and that we weren't just focused on the four walls of a health system. We wanted to pay attention to who's outside of the health system that's not getting served already. And so we felt like the community had to be a part of that, and we really needed to be explicit that this is about inequities. So now we're in our new strategy, and we're thinking about how are we partnering and how are we organizing together with others. We're doing more systems organizing is the best way to describe that, and most definitely I feel like it is a much further upstream process. So I want to end with showing like how is public health social work involved with this. There were many social workers now that came into Health Leads. I felt like I was part of the beginning of bringing more of us in there, and definitely a whole lot of social workers. But there was a slew of different pieces that we had to do throughout all of this. There was a lot of project management, development, a ton of analytics. We built technology. We had clinical care in that. Everything that we learned and that we shared with others has been around what we learned on the ground doing with our families on a day-to-day basis. And so we feel like we have one foot in practice and one foot in sharing and getting all that information out. And so I do believe without the value of all of the public health social workers that we had together at the organization and that we were partnering with in the systems, in the community organizations, I don't know if the health system would be where it is today. It's been a groundswell that really now Center for Medicaid and Medicare is now paying towards this. Mass Health here, the Medicaid offices have completely changed the way that they're reimbursing dollars around this. And it's a new direction for us, and I'm really excited to see how we move further around to the social determinants. Thank you.
Hi, it's so good to be here. I was here a couple years ago when the center first opened and there were learning communities, and I was able to participate in the policy learning community. And it's been fun watching the School of Social Work and the School of Public Health continue to come together, and all of the work that has been a part of that collaboration. So it's great to be here. I'm actually in the School of Social Work. I'm not in the School of Public Health. If you looked at my CV, you wouldn't be able to tell the difference probably from somebody who's in a School of Public Health. And as I'll talk in a little bit, I think that this is one of our challenges when it comes to impacting health policy, which is what I'm here to talk about. Let's see. So when you go fifth in a line of speakers, you run the risk of being scooped. So I will probably say some things that are repetitive, and I think that the bonus of that is that we were each asked to kind of bring what we thought would make interesting conversations. And the areas where you see us mention things over and over again, those are probably places where we need to have some conversations. Or the places we have agreement, maybe we can talk about the things where we don't overlap. But you will see quite a bit of overlap here. So why should social workers care about policy? Because we aren't being ethical social workers if we don't. It's in our code of ethics. We are to right societal wrongs. And I have a former colleague, she just stepped down as the Dean of School of Social Work at Portland State University, Laura Nason. I took my first class with her in my PhD program, and she said that if a social worker was not constantly on the verge of being fired, they were probably not practicing ethical social work. And you know, I practiced social work for about 5 years, and I would say that's pretty true. That if you're going along with the flow and everything feels really good to you, you probably are not practicing ethical social work. And on the way here, I was grading papers of social work students and was just shocked at how many, they were telling me about their placements, how many of them had drank the Kool-Aid. You know, like, well, we only see private pay clients, but we are so kind and generous to people as we give them ideas of where they might be able to go to get care. Yeah, you don't see private, you know, you only see private pay clients because you're in a system that can support that, and your organization has chosen to chase the money, not the people in need. That's a real issue. Social workers should be able to catch that. And yet I find that social work students who take my health policy class often come in with a little bit of dread. Like, why policy? Well, because every person you see, for everything you see them for how long you see them, the people you can't see, all of that is dictated by policy. All of that. And you will end up, like I've been out of graduate school social work for 20 years now, you'll end up like many of my friends leaving social work and becoming real estate agents. Or anything that makes money, right? Because if you're not gonna be happy with what you're doing, you might as well make money. So the reason you need to go into policy is so you will have a rewarding career in social work. And I feel like in health policy, we are uniquely prepared to have a meaningful contribution. We study political science, we study epidemiology, we study history, we are influenced by social movements and social justice, and we learn about the medical model. All of these things influence us, and we're working in every single place where health is created. We're there. So we're able to not just be a bridge discipline, but to be the bridge if we can face the challenges that we have head on and with purpose. We also are a unique discipline in that we are in micro, meso, and macro places. So we aren't just doing clinical practice. We're not just working at the community level. We're not just in policy. We're kind of everywhere across all these policy areas. So let's get to what I think of as our big challenges as a professional, and why it is that I would argue that we don't have enough impact on public policies. The first thing I want to say is we're a little bit uniquely disadvantaged as a profession because we do span so many areas. When I worked in health policy at the state level, I was always like, why we're talking about developing medical home policy for our state? Where are the social workers? Well, social workers are also interested in criminal justice and housing and education and welfare policies and child welfare policies and services for the elderly. So our professional organizations are trying to be in all these places at once, whereas every time a health policy is being considered, the nurses are there, the family practice doctors are there, the specialty doctors are there, the insurance companies are there, the hospitals are there, the primary care association is there, everybody is there but us. So what does this mean? It means that we, all of our students, have to be trained in policy. Because if we don't, nobody's gonna show up. Nobody's gonna show up. I'm gonna get back to that thought in just a second. One of the things that I think we need to do to be able to come and sit at the table with confidence is we need to reject our inferiority complex. And I mean reject it. I'm gonna clap too, yeah. I don't know where it came from. It predates all of us in this room, but I have no time or energy for it anymore. Whenever I hear people say like, oh, well, I don't know if we're welcome. I'm like, who cares if we're welcome? Who cares? It's our table too. We're a huge workforce in the healthcare industry. We belong at the table, and we have things to teach you. And the reason I know this is that the medical model is completely failing. People are sicker. It's costing more. It's taking more of our resources from every other need that we have as a society, gets funneled into healthcare, and yet we're not healthier for it. So no, in fact, not only am I going to reject any inferiority, I'm going to say, let me come in and teach you some of the stuff that we've learned on how to help people be healthier. I believe that social work, and I would say public health, are probably the future of healthcare. Yes, because someday we are going to say we want to pay for health. And when we do say that, because the medical model is not about producing health, it's going to rapidly change things. And you can just see that, because when did we start to care about the social determinants of health? We started to care about them along payment reform, in bundled payments, in ACOs, and all of a sudden we're like, oh, the environment, oh yeah. Okay, well you can't expect us to keep people healthy if they come in sick, because their neighborhoods are sick. And like, yeah, because you're the healthcare system, so you're supposed to get people healthy. As soon as we started doing that, what did we see? A rapid shift. Healthcare-acquired infections, readmissions. When did we hire all the social workers around readmissions? When we said we're not going to pay if they come back because you discharged them too early. And then we're like, oh, social workers. Let's hire a bunch of social workers, because I guess where they live when they leave the hospital really matters, like if they can take care of themselves. So I believe once we really do achieve payment reform, they're going to be coming to us to figure out how to really help people. Our work has been discovered. I was just at the NIH study section last week in DC, and I was reviewing all of the great science that's coming out in health disparities. And I would read these proposals, and I'd be so excited because they're like queuing up everything about how environment impacts health and how we need to address that through cutting edge research and interventions. And then I would get to the intervention section, and it'd be social work. And then I'd look, and there's no social workers on the team. And the intervention isn't described at all. And I'm like, here's why you need to bring us in is because we can tell you some things. And one of the first things I would tell people is that handing somebody a social worker is no good to address the social determinants of health if there are no resources for them to offer. Like, it's worthless. You know, I'm like, oh, you're homeless. Here's a list of housing assistance programs. Get your name on the list, and in 10 years, you might get an apartment of your own. So you need to bring social workers in so we can get you up to speed on what really is happening when you are working with somebody that has complex needs. And we need to bring race, power, oppression, and privilege into these conversations, because I don't know any other profession that reliably well. And yet they are fundamental, because it's not the social determinants of health. It's the structural determinants of health that are made by people, as was said earlier, deliberately. We need to be there so that those conversations will happen. The ACA is a perfect example of that, right? Medicaid expansion, optional for states. What is that? That is a health disparity policy. That means that we have poor southern states with high proportions of low-income minorities who don't offer health insurance to their poor. Well, we have richer northern, western states that are. What is that going to do? It's going to increase health inequality. We need to be there. We need to be naming what we see and making it part of the conversation. So what are some things we can do? I have 46 seconds. When we're talking about national health reform, let's elevate the conversation. Let's not fall into Medicare for all or Medicare for some or da-da-da. Let's just say, what do we want? We want universal health care. How we get it? We want it to be affordable. We want people to be able to see a doctor or a provider when they need it. We need them to have high quality care. And your zip code should not predict your health, right? We need to just stick with it. And then we can evaluate all of the proposals based on whether or not they follow that criteria. We need to be in the states, because states are the playground of health reform, and that's where we can really have an impact. And we know this in Massachusetts, since it was the playground of the ACA. We need a way for people in policy to be able to find themselves. As was mentioned earlier, once people go into leadership positions, they stop identifying as social workers. Well, people like me, if I publish in New England Journal of Medicine, unless I'm from a school of social work, nobody will ever know I'm a social worker. So I could have very easily been in a school of public health because of what I researched, which is health policy. And if I was, nobody would know I was a social worker. That's problematic. But when I worked in health policy, I could always find them because it was the person at the table that made the most sense. And later on, I'd be like, you're a social worker, aren't you? And they'd be like, I am, hi. We need to find a way to organize. And Twitter might be a good way to do that. There might be some tools that we can do that will get us closer to that. And then when we're left out, and I'm going to wrap up here, I'm a few seconds over, but when we're left out, we need to name and shame the exclusions. So the NESM report that came out, the National Societies of Engineering and Medicine report that came out about integrating the social needs into healthcare, social workers put that study together. We wrote the proposal. We fundraised for the study. We made it happen. And then they didn't invite very many social workers to participate. You can bet I'm all over Twitter talking about that. When the Health Services Research Organization, Academy Health, wanted to bring new voices to the table and didn't invite anybody from a school of social work, I put that on Twitter. I'm like, and then they write and they're like, oh, no offense. And I'm like, yeah, offense. Like, we need to be at the table. We've earned a right to be at the table. Invite us or we will shame you. That's my new philosophy. And if you want to see all of my ideas and thoughts and feelings about this, you can follow me on Twitter as well. Thank you.
So I'm the only one who does not have a PowerPoint. Are you disappointed? Really disappointed. And I don't think I really need a microphone because you can hear me sort of, right? Yeah. Maybe? But not online. Okay, I will use this one. So this is going to be really loud.
Hopefully this is working. Okay, so I have been tasked to talk about global health and the intersection with social work and public health. I'm a really bad social worker. I'm just going to be very straight up about that. I'm also a really bad epidemiologist, is where I'm also trained in. And I'm going to talk about how it has been really challenging to wrestle with both of these disciplines in a global health setting. In global health settings that I work in, I'm often in complex emergencies, complex humanitarian emergencies. I work at the edges of war and conflict. And I'm primarily working right now with survivors of torture. And as a social worker, my first response is, hey, I got to deal with a trauma-responsive, clinical strategy to attend to and address profound violations of personhood and self. I got to make sure the refugees and asylum seekers I'm engaged with can be resettled, and that they're not going to go into psychiatric hospitalizations that will cost a system a lot of money. So today I thought I would just tell you a little bit of a story about this wrestling that I'm currently in, and why it makes me a bad social worker and a bad epidemiologist, and why we still need to try, right? The colleagues that you've heard from today are fierce social workers and fierce public health people, and I've learned from them. But I have to say I'm still struggling. And to be completely honest with you, this is the landscape where interprofessional work is profoundly challenging. How do we bring together the total stream, the system, right? Not downstream or upstream, but the whole damn river, right? The whole stream. And how do we engage thoughtfully and mindfully that's profoundly participatory, not top-down, but deeply participatory? To liberate, right? Not from disease, morbidity, and mortality. We all want to try to do that. But really to go through a thoughtful process of engaged healing, knowing that we may never get there, right? So Wendell Berry, people know who Wendell Berry is? Often is quoted as saying, there are no unsacred places, there are only sacred places and desecrated places. So I'm going to bring you to a desecrated place, the Middle East, where I do a lot of my research. And we're working on a large psychosocial stabilization project with the EU in refugee camps in Iraq, Jordan, and Lebanon. Okay? And working with refugees and asylum seekers who are systematically and profoundly violated, who've been enslaved, who show up at a refugee camp, and encounter a human rights officer, right? And then they encounter the healthcare system, right, in these camps. And I was called in because I'm primarily an epidemiologist. I'm seen as one. And they're going, Fernando, can you help us figure out how to reduce, right, symptomology, because they're going to be resettled in the West, in places like the Netherlands and Scandinavia primarily. I'm scratching my head, I'm going, wow, you want an epidemiologist to do that work, to figure out how to reduce, right, psychiatric disease, morbidity, and mortality presentations at, potentially at your hospitals, right, in the Netherlands. So my social work side of me is going, hell, what is that about? Because there's a lot of inequity already. You've already set it up. They're going to cost you something. This is not a rights-based approach to public health. This is not a rights-based approach to public health. When I teach my medical students, I often say we are stuck in charity-based and needs-based approaches to intervention, design, and strategy, right, that calls us in together and coalesces our skill sets, right, to attend to and address what we in the West, right, need to happen. You can't cost a lot. And individually, it's okay. You can come to my church, right? You can come to my community center, right? But ultimately, in aggregate, as a population, oh, hell's no. You already reached a threshold where I'm gonna get nervous. And this is where we're at. I'm struggling because, as a social worker present in this space, I'm having to inject, right, an understanding of what is profoundly the social determinants of health. And even beyond that, right? Because I would argue we haven't reconnected to other aspects of the social determinants of health even more deeply, like spirituality. Have you guys thought of that? Right? We're really stuck in this biopsychosocial approach, even as social workers, that I'm struggling to understand how to reimagine meaning and purpose in community lives, in places that they don't feel belongingness or home. Global health social work and global public health coming together connects profoundly to ideas of a larger systems approach that is deeply interprofessional. How do we talk to each other? I'm often feeling like I am schizophrenic, that there are parts of me, right, that understand one or the other. And it's illustrative of our vertical approach to this psychosocial intervention design that I'm working on. And I'm trying as a social worker in an epidemiological space to tilt it horizontally. We are damn good at horizontal integrated approaches as social workers. We are good at understanding the whole stream. And we have the methodology to do that. But we can't fear our power, right? And we can't fear the privilege of leveraging our methods, our perspectives, to do whole systems work. Right? That is hard when there are pressures to push us more vertically. Fernando, you can only do the clinical piece here. Once they resettle, we're going to separate the clinical piece with the more, what you want, the more integrated piece to deal with housing, employment, food security. Even more so, how are you going to recreate in a participatory way, belongingness, spiritual dimensions of health? What does it look like to do that? We can't do that, Fernando. You're not funded to do that. You are funded to do, right, reductions of psychiatric presentations. Make sense? So I'm frustrated. We are on these teams together. There are no social workers other than myself on this team. And I happen to be on this team not because I'm a social worker. It's because I'm an epidemiologist. And I'm like, really? I'm going to actually articulate what it looks like for a global health social worker to be at this table. And it's pushing this envelope to the edge. Amina, who came to the refugee camps 3 years ago, her people were engaged in a genocide, what I call a genocide. She was enslaved for 2.5 years, a survivor of torture. She came to the refugee camp. All her people were obliterated or annihilated. And I won't go into the details of this profoundly traumatic story. But she came in presenting, rightfully so, with what we biomedically, as clinical social workers, right, would say PTSD, right? Anxiety on the spectrum, right? But we were left at that diagnosis because the human rights officer said, we're going to take her away from you, right, to be able to deal with the other health issues that she needs to deal with. And I'm like, no. How do we stay at this table? How do we reinsert ourselves so that we say that we don't just do the clinical encounter? That I can follow Amina and her cohort, right? The individual of Amina and her people, right? As she traverses towards resettlement, to work with her lawyers, to work with her food security folks, to work with her community of practice, like a spiritual community, to engage with her beyond her presentation. That to me, right? That to me is connecting to the whole arc of what we need to do as an integrated profession. Public health cannot exist without us. Public health cannot exist without us. But we haven't taken the chair at the table to articulate strongly that we belong, right? Just as Amina belongs where she needs to belong. And how can we engage in a participatory way around that belongingness? Does that make sense? So I apologize I don't have these PowerPoint slides here, but I'll just tell you, when I follow Amina and that cohort of folks in that first epidemiological phase, right, to where she is now in Amsterdam, in the Netherlands, she looks at me and she says, Fernando, you're not my therapist anymore, are you? I'm like, no. And I never really wanted to be, because I'm a really bad therapist, right? But I wanted to walk alongside you to understand how we right, a wrong. I can't erase it, right? But we can try to figure out together with your community, right? And with my community of practice, to try to think through, what does it mean for you not to be home anymore? What does it mean for you have to sit consistently with your trauma? What does it mean for your community, right, to be consistently still targeted? What does it mean for you to have to navigate through systems of oppression and racism in the country now that you've been resettled in? What does it mean for me to be there with you? And how do I show up where you're at? And can I follow you together with my community of practice and with your community that is engaged in this suffering to work together towards liberation? And people are like, well, Fernando, what does that really look like? And I will tell you, I do a lot of systems work, right? Is to say that it's not necessarily always outcomes oriented. Can we change and shift our perspective to include the process for which we dynamically engage with contextual realities that are understood or splayed out over the course of, right, structural violences, right? And we as social workers are really good at that. I deeply believe that. Talk about drinking that kind of Kool-Aid. That kind of Kool-Aid to me was understanding systemically. I took Dr. Sprigg-Martinez's class, by the way, right? Understanding how it is not separated, right? This macro and micro. And that our perspective as social workers can actually teach the biomedically driven positivist epidemiologists that were more predominant in this room to say, hey, stop, right? Let's pause. Let's stop this intervention, right, railroad, and actually wait and listen, radically listen to the populations we're engaged in and how they're navigating, right, from one place to another. It just so happens Amina is navigating from the northern Iraq all the way to Amsterdam. That navigation and her resettlement in Amsterdam, that navigation requires us to be radically aware with her about her radical presence where she is. We were talking a little bit about how we educate future social workers and public health professionals. It is that integrated practice. If I had my druthers, I'd rather have done a theater of the oppressed with you to talk about what this is like for me. But it is how we rethink our pedagogical strategies to be more creative and imaginative, right? We have a space for that in social work to re-inject very biomedically driven public health landscapes. What does it look like to transform that, right? Everyone asks me, well, how are you radically transforming Amina and her people's lives? I'm like, our transformation needs to happen first. How do we understand that transformation begins with us to be able to help the other? And not in this us-them reality, but do the work, right, of understanding the structures of violence and the systems of oppression that engage with power structures that systematically continue to deny groups of people like Amina, right, full thriving in the world. So my message to you today is not, hey, I really have no answer, right? But it's to say that the reason why I started out going, I'm a bad social worker and a bad public health person is because we are in consistent evolution to strive for better, to do better for the people we serve, not just as individuals, but as communities, and how those communities contextually are living a life that may be engaged in suffering, and how do we support them through and liberate that? What is the stake at our table of what our commitments are? For me, it's about how we can connect to communities to re-engage in imaginations around belongingness, that we don't see this differentiatedness, but to recognize that differentiatedness comes from the inequities, right, of power that exists in our structures. We are good at that as social workers. In global health practice, this is hard. I am constantly struggling and coming up against this notion of, Fernando, take off that clinical social worker hat or that social worker hat. Engage in the M&E, the monitoring and evaluation that will give us the numbers, that will give us the epidemiology. Did this intervention strategy work? Are we being effective? How do we need to adjust the strategy? And you're keeping on wanting us to go horizontal. You keep on wanting us to think about where power and agency is. You want us to think about what governments are doing. How do we stop things like war? How do we engage in soft diplomacy, right? I don't know what else to tell you other than this ongoing evolution to work toward what I consider a true integrated, right, transdisciplinary, uber inter and intraprofessional, right, engagements within a dynamic, right, systems ecology, right? A systems reality that really attunes us and tunes us into, right, local, right, community, and global realities. Thank you.
I want to invite our panelists back up to the stage. Thanks very much. So what we've heard are a number of different perspectives about thinking about social work. In large part, we're thinking about what does it mean to be at the table. And we've heard in particular that we have the power and that we have the skills, but sometimes there are pressures that prevent us from being able to do the work. And Heidi has suggested that our biggest problem is that we have an inferiority complex. So I'm going to come to you in just a moment to talk about, so what does it take for us to be at the table? But I'd like to talk initially about, we are certainly aware that we certainly have lots of skills that will assist us in being a good person at the table. And it just might be important, even in this room, some of which I suspect are many social workers, but perhaps some that are not social workers. It might be important for us to say, what is it that we bring to the table? What do we bring to the table that we think that is so important to address the issues that we've been talking about today? What do you think? I get to ask the questions. Yeah. I mean, you know, my job is to stand here, be the eye candy, and to actually just ask questions. So what do you think?
I don't know who you're asking. Exactly. Did you have any one of us in particular you wanted?
I'm actually kind of talking to all of you at the same time.
Well, I think that we're like Harry Potter. You know, when there was that thing that said, I open at the close. Yeah. You know, social workers are with people during the most difficult moments of their life. And that requires a tremendous skill set of evidence-based approaches, but also radical humanity, the ability to sit with people when they're in pain, and then to navigate with them the complexities of their life. And I don't know quite how we've managed to learn how to do that as a profession. I think we draw from we're like the Weight Watchers of diets, right? Like, we'll do whatever works. You know, if you find us something that looks like it works, we'll adopt it. It'll be in our curriculum next year. And I think that that's one of our strengths. It also is kind of where it gets hard to determine our worth, because you can't randomize that shit. You just can't, right? And so, you know, we're the gap fillers. We're the person that, you know, the doctors send in then when they're like, oh, I don't even know what to do with the person in acute 9. Would you go in there and, like, you know, whatever you guys do? And whatever you guys do is very, very complex, but difficult to put to some kind of study that demonstrates our efficacy. And one of my concern with all of the new research that is using social workers without naming social workers and without fully specifying what the intervention is going to look like is that it's going to end up showing us not to be very effective because they don't know what to measure.
So I want to stay with just this part right now about what we offer, because I'm going to come back to a little bit more and talk some more. But so you're saying that one of the things that we offer is that we are navigators. We help to fill the gap. We work with people at very difficult times. What else? What else is it that we offer as social workers?
I think we're also able to bring people together from across all aisles. I think that social workers have a really unique ability, and perhaps it's because they have feet in so many different worlds, but they're really able to convene and to bring people together.
Okay, conveners.
And I would add, I want to piggyback on what Linda just said, because I think part of what makes social work such an important profession is that we're everywhere. And our diversity is our strength. We're at all levels of practice, and we're across all the major social welfare systems and beyond. And it's hard to find another profession that goes as far, as wide as we do.
Okay, so we're conveners, we're navigators, we fill the table, we work with people who are we work with people at difficult times in their lives, and we are everywhere. There's a diversity of who we are. Something else? It's on.
My husband probably wishes he could turn me off like that.
He's not in the room. Yeah, no, we won't worry about him right now.
But I think the other thing that social workers have this magical power to see systems, right? And so I think that when
what does that mean, magical power?
Magical power. I think that when we look at a situation, we see the different systems at play, and we can see kind of the politics, because everything is political, and so how things come together, who relates. We're always looking for power. Where does power sit? How is it moving? How is it operating? And then how can we insert ourselves to shift it? And I don't think that all folks operate that way.
Yeah, Jennifer, you're going to add something?
Yeah, I was just going to say, Linda, so I think the public health social work lens comes in a little bit differently in that you are dealing in the day-to-day crisis mode or whatever may be happening, trying to intervene, and the public health piece comes in and says, why am I continuing to intervene every day on this? Like, let's fix this and let's prevent this in the first place. And it's that magical combination of the two that I think gives a really well-rounded lens to it.
And that's why I think I would say that it connects to really integrate. We're integrators in a lot of ways. We're systems integrators. And we can integrate systems really well, however magical that is. But it's actually really, I think we're intentional about how we integrate and how we perceive things like power, agency, oppression, structures, but also even more downstream, like how people present and why they're presenting it that way.
So we are integrators, and in particular, we are intentional about the work that we do. So given that, so I wanted to actually say that because it sets the stage for saying that we have something to offer. There's something that we do in our skills, in the training that we've received, that we have something to offer to the table. However, we've also said that we are missing from some tables. So what tables are we missing from?
All of the ones where health policy decisions are made, I would say.
Anywhere where health policies are being made.
I mean, this is the only
Dr.
place where I
Lewis
have
would probably agree with
expertise,
some
but
of that as well. Would you like to come join us?
please come join us.
Sure, come on up.
Oh, is there a seat?
Yeah, and a microphone. See what happens when you start talking, Welcome. Okay. All right. So I'm sorry, Fernando?
Sometimes I wonder if how much we're orchestrators within sort of specific environments. So in global health settings, people who are orchestrating interventions, programs, and all of that are not necessarily the social workers. We come in later if someone brings us there. But often what I'm seeing is that, at least in the spaces I'm working in, it's mostly public health folks that are coming in primarily. And then if there's someone like myself who's like, wait a second, why aren't there more social workers here? Then we come in. But we're not necessarily orchestrating and leading in specific arenas. Not always, but it seems like, at least where I'm going with global health practice, I'm like, where the hell are the social workers? They should already have been here. They should probably have conceptualized the framework, right? They should have conceptualized the intervention strategy. Instead, you have a whole bunch of public health people. I'm not, excluding myself, but they've been the ones who've been asked to do the intervention, like initiation of the intervention and the initial implementation. And that's one of the challenges I'm facing, is that why aren't we having the social workers actually beginning that process in very powerful places? They may be in Washington lobbying and advocating, but in the practice world that I'm in, it's really challenging to find a lot of social workers there. I see a lot of epidemiologists, biostatisticians, behavioral health scientists that are in the public health disciplines in these global health spaces. But it's been more challenging to find social workers there who are leading it, who are really leading it.
Betty, you were raising your microphone.
I was, but I'm going to pass.
Okay, so we have to be invited. We're not at the table initially, it sounds like, and we come in at a later time. And so I'm still interested in this business about what tables are we missing from. Heidi says any place that deals with policy, we're missing from them. Any place else we're missing from?
Well, the highest levels of leadership across a multitude of institutions that we work in. And part of it is that we don't train for leadership sufficiently within our profession. And when we do, it's not clear that we have sustained an infrastructure of leaders out there to bring those people along. So I think we have our work to do, and it's a piece of what we've been talking about in the leadership core at the center about we need to kind of start basic and identify who our leaders are. We need a lead. We actually have called it, we're starting a leadership identification project.
Yeah.
So.
Charles.
If I could comment on that, when Heidi used the word inferiority complex, it never dawned on me that could be a situation that because when our national social workers national organization, NASW, right, they spend a lot of money hiring lawyers to navigate the Hill. Okay, they hired this. When I'm saying, it made no sense to me because there have been a lot of social workers on the Hill, like me and others, who know that space, who can navigate that space, but they would never think of hiring me. You know what I'm saying? They believe that they need that high-powered, so there is a way in which we might have to check our, our leadership, as you say.
So I'm asking those questions
can
because
I
I
say
want
something about that real quick?
Yeah, please go right ahead.
Sorry,
Sure.
'cause I just feel like that's part of the medical model, and the problem is that because the medical model is dominant in public health and in healthcare, and economics dominates the part of healthcare that the medical model doesn't, we're just so glad to be there, and we're like, well, we just want to learn your words, and we train our social work students like in medical terminology and how to practice. We're like, let's socialize you in the medical model so that when you go, they'll like you. When that is not how it should be. It should be we have two different disciplinary strengths that we can bring to the table, and it's going to make the table a better place to be.
All right.
But
Now,
that
so let
inferiority-
me push a little further, because we've now established that we have something to offer. We've established that we are missing from the table. Now, the bigger question is why? Why are we missing from the table?
I think I have a little bit of a different opinion on this.
Oh,
Betty's
okay.
heard this a few times, and so
Sure.
I actually think we need to stop asking. We are at the table. We are invited. There are people in leadership in social work roles, and I think the more I hear around I think this is the same conversation we've been having for at least 20 years that I've been in social work. Of why don't we get the respect? Why aren't we at the table? And I think that's part of our problem. Is people just, you show up at the table and you're there and you show your value when you come with the around the conversations. And so that I may be coming up against very different opinions on that, but I think we spend too much time on questioning our value. I think it's part of that inferiority complex, and instead to just say, where are we leading? So then all of us can go out and
let me ask
remind
you,
people
are
of
you
that.
and Heidi in a different place? Because I think I hear something slightly different, but are you saying something similar? So I think what I hear is we've got an inferiority complex. We're not at those policy tables, but then I hear Jennifer say, yes, we are at those
So I
policy
don't know
tables.
about policy.
So we're not at the policy tables.
Yeah.
I mean, we're just not. I don't think that that's necessarily the function of the inferiority complex. I think that's because we're so spread thin across all of the different issues that we care about, and we don't train our students about how to participate in policy, so they're not stepping up for us. So we don't have associations like the Nurses Association and the AMA that can show up to all these policy tables. Like they can't be at all the tables where we care about where the policy is. So it's gonna have to be social workers, but all they do is take one policy class that covers like the child welfare law. Well, my school, they only take one. Child welfare law and the Americans with Disabilities Act, and they never actually I asked them how does a bill become a law, and they're like magic, I don't know. So how are they supposed to engage? They don't even know where it's happening. I feel like that's really problematic if we have a discipline that can't pay for professional representation at all of the tables.
Betty.
So I do think this gets back a little bit to how we train people. I think there are two things I want to just mention. One is in a focus group that Jeff Wilkinson and I did, these were not confidential focus groups, so I can out us. There were a number of people who were here. One of the things that came up was social works, and this relates to the inferiority complex, almost baked into us as an allergy to power. And that we talk about maximizing power for other people, and we talk about deconstructing powerful systems oppressing people, but a lot of times that gets mixed up in our own heads with, do we really want to have power in systems, and a kind of sort of professional ambivalence about power. So that's one thing. The second thing is our professional organizations, and I'm sorry and I apologize to anybody who's in a leadership role, including myself, in a professional organization, they're not doing the job right now. It's not getting done in terms of representing us and moving us forward. And I don't know what the issues are, but I think it has something to do with the disconnect between social work education and social work practice. And we have to wrap our heads around that. And educators have to come forward, step forward. And because practitioners need educators and organizations to do more in the way of advocacy, and we need to get, I know we don't talk about the wingspan anymore, but you know, that's like what we gotta do. We gotta bring in the 85 different organizations that represent social workers into some formidable mass of of organizing that can start changing this representational vacuum that we have.
Fernando.
But I also think that we need to, you brought this up, Dr. Ruth, the idea that we have to model leadership, not necessarily in a traditionalist kind of way, but really understand that we may be different kinds of leaders that respect and understand these systems of violences that we ourselves are practitioners in. And I think one of the challenges is that I didn't get this in social work education when I was going through, is this, how are we systematically paying attention to working with our current leaders that we may or may not have identified or defined yet at whatever tables they are, and really engage with them to mentor, right, us to become, because they're amazing leaders, because they actually engage in humility, right? They engage in understanding not only their humility, but how they may be, right, complicated, like in complicated relationships where power exists that may oppress, right? And I take your point serious, is like, how are we innovating around, leadership and leadership education and mentorship, right? How are we also mentoring each other?
All right, we are not of one mind. That there are multiple minds here. And I think the thing that we're hearing certainly is that there are some tables at which we are at, where some, might think my English teacher would like what I just said, but there's some places where we are. There's some places where we need to be. And that it's important that when we are able to be at those places, that we do not, as Jennifer has suggested, show our inferiority complex, and that we should embrace the fact that we're at the table. So now I want to turn to you and ask you, so are we at the tables? What tables are you at? And how come we're not at the ones where the policy work is actually being made? Yeah, sure. So yeah, we need a microphone. Thank you.
So honestly, I have so many thoughts, I barely know where to begin. I mean, one thing is to the point that was made about we can't possibly show up at all the different spaces, but I think all of us as social workers are constantly trying. So, we go to the State House for the criminal justice reform, and then we go to the State House for homelessness, and it all affects like our clients because they can't get jobs because they have a quarry, and they can't get jobs because they're homeless, and you're exhausted, and then you want to join that group mentoring, group supervision, and you're too fried, and you can't maybe pay the dues or something, and you can't decide which professional organization to join because shit, they're so expensive, and what am I gonna do? And anyway, I don't get paid enough. So that was me just unloading a moment, but I guess.
So your point is we're stretched thin.
Yeah, I mean, yeah. Right. I mean, I gave up 4 things to be here today, right?
Yeah.
And that was important. It was important for me to be here, but there are 4 things waiting for me tomorrow, but oops, I'm at a different conference tomorrow. But I will be there Thursday, and my head will be spinning. And that's my job, and that's what everybody sees. And I have previous staff here who would vouch for the fact that I'm, unable to be found in the building 99% of the time. Anyway, but the point is about, who we are as social workers. I find that I do sit at tables. I'm exhausted. I arrive there late, and then I look bad because I arrived late. But I then don't know how to distill that magic sauce that everybody keeps talking about. The complexity with which we approach the work we do is so profound, and nobody gets it because we're holding the bio and the psycho and the social and the person and environment, and we're looking at development across the, the life stages. And I mean, like, then I'm gonna bring in psychodynamic or psychoanalytic thought, and like the unconscious is actually functioning here. Like, what? No, like I don't know how to say it to be heard when I'm talking to the business person. I don't know how to say it to be heard when I'm talking to the homeless agency. I don't know how to say it to the sheriff. There's too many languages I'm trying to traverse. And so that global, the global social work, I mean, it's global social work every day, every moment, in every way when we're trying to cross the professions. And I do think that there is something that everybody was touching on, and I'll wrap it up in a second, that we have to own our power. And I think the power doesn't have to be like power with a capital P, like we're oppressors' power, but what is our power and how do we name it, and what is that special sauce that gives us power? Because people look at us as if we're magicians, but Lord knows I don't have any magic. Like, I get up every morning, I hopefully have breakfast, I get to work, I work my ass off, I maybe get home to see my daughter in time to go to bed, and like, then I get up and do it again. And there's no magic in it. Like,
I'm going to stop you.
Yes.
Yeah. So what I really appreciate you saying is the importance of being stretched thin, and also the importance of needing to be able to address the issues from many different perspectives. Why else? What do others think? Why are we either not at the table, or what is it that we need to do differently? Here's some. There are microphones there. Yeah.
First, I just wanted to say that I've really, really enjoyed all the speakers. I think you're all amazing, and it's just very refreshing to be at a social work-y conference that isn't just clinically based, that we're talking about the issues that we really face every day with our clients. I happen to be a supervisor for a basic needs program with emergency financial assistance and other kinds of basic needs support. We're talking food, utilities, housing, those types of things. And going back, there's a few points that I just wanted to address. One is the whole idea of invisibility, that you're not a social worker, you're a case manager, you're a therapist, you're a clinician, but you're not a social worker anymore. That's one thing. The other thing is, in terms of internships and students and education, I'm far from my degree at this point, but I've supervised a lot of students, and one thing that seems to be a common theme is they're getting a clinical training, that's where the emphasis is. You go into clinical work without understanding that there's a clinical framework for even helping someone fill out a mass health application. That's kind of below you. We're talking about systems and how important it is and how difficult it is for so many of us and our communities to navigate these systems, yet they need them so desperately. But no, we don't do applications. You can go to your community center, or you can go to your healthcare navigator at the hospital or at the ER, but we don't do that kind of stuff. Or I think one of you mentioned too, just the time in life when you were a therapist and didn't know what housing was. If everybody's operating in silos, and the ultimate pinnacle of being a social worker is to have a private clinical practice, then what's going to happen to all this other stuff? Because this is really where it's at. And there has to be this de-emphasizing of only therapy and only private practice, and even worse, just only private paying therapists. Just one small example, I have a staff that I supervise who are social workers with MSWs and who want to progress and get an LICSW, and to put in the application now for them to just sit for the exam, we've been turned down repeatedly because they're not clinical enough. And these are folks who work with clients who are coming in the throes of crisis. They're being evicted. Many of them have significant mental health issues, so you need to understand these things. Yet, for whatever reason, out in the field, this is not happening. And you're talking about how to develop leaders and how to be a mentor. And at my stage in my career, that's where I'm looking at. Who's going to be coming up next and who's going to be doing this work. You can't get them in LICSW. You can't even get us to sit there, and this is within our own organization. So, again, I commend all the work you're doing. I also hope that you'll...
Thank you.
I just want
yeah,
one.
I'm-
Can I just ask one other thing? Is that you
Certainly.
leave us some communication that we can get in touch with people at the end?
That'd be incredibly important. We'll make certain that there's
That's it.
information available to make contact with others. So in the last couple of minutes that we have in this conversation, I want to just turn to just one last piece. What do we do differently? What is it that we should do differently? And so what I'd like for you to do is to give me a one sentence of what is it you think we should do differently. And I want to say the same thing for our panelists. But we're going to pass the microphone around quickly, but just one sentence, a short sentence.
Oh, hi, thank you. Heidi, just to let you know, I'm following you on Twitter now, so be looking for your tweets. Everybody needs to make sure they're registered to vote. Everybody needs to know who their local state senator, state representative is, and make sure you get out in November 2020 or the next election and vote. That's the best way you can use your voice.
Excellent. What else? Yeah, back there.
I think we need to crisp up the message.
Crisp up the message. Yeah.
Say we need to continue to empower women. We are still mostly a women's profession. So when Heidi talks about, being at the table and feeling like we're not there, we really need to feel like we belong there and speak up for the women.
I just want to reaffirm what a huge aspect of, I think, this inferiority / allergy to power thing is gendered in our profession.
Couple of other hands for around the 1 minute, the 1 second, the one sentence, what we should do.
I hope 3 sentences are okay.
Okay.
I want to
3
just follow
sentences.
up on the woman down at the end that just spoke a few seconds ago,
Yeah.
because that's really why I came here. Because I'm a consumer as well as a provider, and I can't tell you how many times in the past 3 years I've been told by service providers exactly what she says happens in her office.
Yeah.
And it's incredibly frustrating, especially since I have the professional and educational background. When I get told, no, we can't do it, and you're a smart woman, you can figure it out on your own, and I tell them, if I could figure it out on my own, I wouldn't be here. So what I was hoping today is that you as educators could find the answer to this question and work together and come up with the answer, because my health has worsened because I get answers like the one the woman down there was talking about.
And it's because of individuals who are in need that social workers do the work that they do. Thank you very much. The point right here.
I was just wondering if, just having stepped back and after taking some time off raising my family back to social work, because it's been a while since I got my MSW, if there would be, if BU could do a CEU sponsored leadership kind of program.
Yes, we can.
And here's Dean Delva. I'm certain that he'll certainly be interested in hearing about suggestions that you have for his program. Thank you very much. Yeah. Right.
Dr. Lewis, what is your candid opinion of the ASW as leadership for social work? Politically, and compared to the NEA or the nurses?
I think NESW does some good work in terms of representing the profession in that sphere. I think they could do a little better. They just hired a director of public policy, so I think they're heading in that direction.
So let me now just turn to our panelists. Last thoughts that you have for what we should do differently to address this issue of who's at the table, how do we make certain that we are at the table, or even this matter about how do we deal with this business about the inferiority complex that we may have ourselves, that we may be forced upon us. 1 sentence each. You want to start?
I think we need to change the way we educate students, and by increasing the leadership training and by strengthening the integration of public health content in our curricula.
Thank you.
I would agree with Betty. I also think that we need to really focus on professional identity development as social workers and embrace it. Oftentimes, we don't do that in our schools, and so I think focusing there. I also think from a leadership perspective, as we're training around leadership, there's a lot of different places you can lead from, and I think that social workers are at many tables. They're in, they might not be in a traditional leadership role, but there are social workers leading from the bottom, there are social workers leading from the middle, and so I think that how do we as a profession recognize that, embrace it, and elevate it?
Thank you.
I'm going to move to the policy side. I think you might have influenced me a little bit. I think probably, what I heard from this too is NASW. How do we get more involved in that? How do we have our own voice at the table? And if NASW is part of that, or they're the organization that represents us now, and we're not very loud in there. We're not very represented, and so let's move forward and do more of that.
I've said a lot of my opinions, so I'm not going to throw any major ones out new. But I think that training all students to understand how policy works, and then maybe creating more opportunities that don't have a paywall. So not a CEU price, not a membership, but ways for us to come together and find each other and elevate our voices where we can do it quickly and for free. I think so all the new technology platforms, I think if we can become literate in that would really help us gain voice.
Thank you. Fernando?
So how do we amplify sort of our mentorship, our existing and mentorship sort of systems, and innovate around that to feed into this leadership model that it's at all levels, you're right. And just to remember our fierceness, to really deeply remember our fierceness.
Thank you.
For the past 3 years, we've been doing a boot camp, a political boot camp, where we train social workers who want to go into that political space. And so we have to be deliberate in terms of helping people to do that.
Thank you for being here this afternoon. Please thank our panelists.